Hi, this is Dr. Patterson, and this lecture is on the integumentary system.
The first few slides are just a general review of the anatomy and physiology of the skin. It provides a barrier, regulates body temperature, includes the synthesis of vitamin D, allows sensation or sensory perception, can provide us with nonverbal communication and identity, assists with wound repair, and allows for the excretion of metabolic waste. This slide is a good visual for the different layers. The first layer is the epidermis. It is superficial, thin, with no blood vessels. Then there is the dermis, which contains blood vessels, connective tissue, sebaceous glands, wet glands, and hair follicles. And the inner layer is the subcutaneous or adipose tissues, which connects to underlying structures. The health history is important in helping us identify the diseases of the skin, underlying systemic conditions that may have skin manifestations, pressure injury risk for other diseases or skin cancer, can be indicative of signs of physical abuse, and it assists us with understanding the need for health promotion. When we take a health history, it is important to document the history of skin diseases, diabetes or peripheral vascular disease, allergies or food sensitivities, sunburns, corticosteroid medications, which can cause thinning of the skin, medication use, which may cause allergic reactions and or rashes and photosensitivity. An immunization record is also important because it can help us to further rule in or rule out certain disease processes. We also want to think about lifestyle and personal factors that may affect the skin, such as certain bath products and soaps, certain ingredients and cosmetic materials present in false nails, wigs, hair extensions, and false eyelashes, paying close attention if glue is used, and also the frequency of sun exposure, exposure to chemicals and or radiation, and diet. It is important to be thorough in this area because it can help us connect possible signs and symptoms a patient may be experiencing. Our first question asks us the following. The skin is recognized for performing which function? A. Temperature control. B. Synthesis of vitamin K. C. Excretion of excessive electrolytes. Or D. Motor perception. The answer is temperature control. The functions of skin include synthesis of vitamin D from sunlight. It provides a barrier for protection and regulates body temperature. It also provides sensory perception, identity, allows for wound repair, and allows for excretion of metabolic waste. So when we begin our physical exam of the skin, we will start with a general survey. You may start gathering information for your general survey when you enter the room and you're greeting your patient. You will then ensure that the patient is properly draped and start inspecting. Upon inspection, you will pay close attention to color or variations, including but not limited to increased or loss of pigmentation, erythema or redness, cyanosis, pallor, or jaundice. I wanted to start with talking about abnormal colors. You may begin collecting this information with a general survey or even while obtaining the health history. You may start to notice a patient's eyes, lips, nails, or palms while just speaking with them. One indication of the physiologic processes going on in the body is the color of the skin. Jaundice, or the deposition of bilirubin, is easiest to see in the sclera, nails, palms, and soles, and can be visualized in severe liver disease. Another color that I want you to be familiar with is cyanosis. Cyanosis is referring to the bluish color of skin, which is indicative of decreased oxygenation. Common areas that you may see this are the lips or extremities. This slide provides a nice visualization for common different skin color changes. The first one being carotenemia, which occurs with a diet high in carrots or yellow vegetables or fruits. Although not necessarily harmful, it could indicate the need for further assessment of dietary intake. The difference between carotenemia and jaundice is that carotenemia will not affect the sclera. The other pictures include examples of jaundice, cyanosis, and erythema or redness. On the left, you can see an example of vitiligo, which is mostly due to a genetic origin. You can see the lack of melanin in the skin. You may have also seen cafe au lait spots before. These are typically benign. However, if a patient has 6 or more spots, this suggests a genetic condition called neurofibromatosis. And on the far right, you can see an example of acanthosis nigricans. You can see the thickened, darkened area in body folds increases. In this example, you can see the back of the patient's neck. This condition is mostly associated with an increased BMI and/or diabetes. This slide is an example of tinea versicolor. This is a common fungal infection that causes hypopigmented macules, typically on the trunk, neck, and upper arms. When palpating the skin, you will pay close attention to any moisture present, excessive dryness, sweating, and/or oiliness. Skin should be dry to the touch without flaking or cracking. One area you should carefully inspect are the skin folds because these locations are commonly missed and often the location where you may see eczema. Skin folds are also an area with excessive moisture. Increased moisture in areas with increased heat equals an increased risk of infection because it is a bacterial and fungal breeding ground. Under the breasts are one common location for a fungal infection to present. Make sure when assessing for warmth or coolness that you use the dorsal aspect of the hand or the back of the hand. While observing and palpating the skin, you also notice the skin's texture, mobility, and turgor, and edema. Skin turgor is helpful in determining the hydration status of your patient. It involves lifting the upper fold of skin and noting the speed in which it returns into place. However, this may be impacted by a patient's age, specifically in older adults. It becomes less reliable with thinning of the skin. Edema may be caused by a variety of things like heart failure, localized injuries, or other systemic illnesses. DVT and also a low albumin level are all causes of edema. Be sure to be familiar with the differences in non-pitting and pitting edema. This is the pitting edema scale, with the higher scores corresponding with the depth of the pitting. Question 2 asks, during your physical examination of the patient, you gently pinch the back of the hand. The skin remains in a tent shape and slowly returns to its normal position. This is a sign of A, infection, B, overhydration, C, dehydration, or D, properly hydrated. The answer is C, dehydration. Tenting is a sign of poor turgor and occurs when a patient is dehydrated, often occurring with excessive vomiting, diarrhea, or heat-related situations. The patient should be further assessed for the need of intravenous fluids. When observing lesions on the skin, it is important to note the color, including if the color is uniform versus a variety of colors, size, elevation, number, and texture. Is it smooth or rough? For the type of lesions, refer to the primary skin lesions chart in your book. It is also important to note the shape and pattern and anatomic location/distribution. Is it a cluster of lesions? Is it linear? This is an example of psoriasis. You can see the red silvery scales, especially on the knees and elbows. Atopic eczema is a very common condition. It looks like flat, scaly lesions, often located on the extensor surfaces. Make sure to review the different patterns and descriptions of skin lesions, primary, secondary, vascular, and purpuric, in table 9.4 through 9.7 in your books. I've posted some pictures of common primary lesions in your slides. Personally, I think that pictures are the best way to learn about the different skin lesions, patterns, etc. The left picture is an example of a linear lesion, often found in herpes zoster, and usually aligns with a specific dermatome. The picture on the right is representative of a geographic lesion. Annular lesions are seen mostly in fungal infections such as ringworm. This slide summarizes some of the major primary skin lesions. Papules, nodules, cysts, and wheals, often seen in urticaria or hives. Vesicles are serous-filled blisters seen in varicella or chickenpox. Also, there is a picture of a bulla, which is also serous-filled, clear to clear or yellowish fluid. You may see this in patients with profound edema. I have seen this in practice in older adults with extensive lower extremity edema called bullous pemphigoid. You may see burrowing or tunneling in the skin, often located between the fingers or toes. This can be caused by mites that cause scabies. Question 3 states that vesicles in a unilateral dermatomal pattern are typical of A. herpes zoster, B. herpes simplex, C. tinea capitis, or D. acne vulgaris. The answer is A. herpes zoster. Herpes zoster, also known as shingles, forms vesicles that follow a dermatome of the body, usually the trunk. These usually occur only on one side of the body or are unilateral. Skin assessment is so important in patients with decreased mobility, post-surgical patients, intubated patients, and/or older adults. They are especially susceptible to damage and pressure injuries, which can be exacerbated by shearing forces. The name of the assessment tool that we use for predicting pressure sore risk is the Bradian scale. I really like this visualization of the different pressure injuries and stages. Pressure ulcers are very difficult to heal, so prevention is so imperative. There are many different interventions for prevention. If you work in a setting in which a patient has decreased mobility, it is essential to frequently turn and reposition the patient. Hospital settings have special mattresses that you can order for patients. When you are assessing locations such as the back or the sacral area, for patients who have pain with movement, it may be helpful to wait to assess these areas when you are already turning or changing the patient, or if they are up in the bathroom. In nursing, planning and clustering your care is not only important for your efficiency and time management, but it also increases the quality of care and life in our patients. I think hair is sometimes forgotten when thinking about the integumentary system. However, by inspecting hair for quantity, distribution, texture, and different changes, we can learn a lot about underlying pathologies. For instance, someone with hypothyroidism may have thick, coarse, and dry hair, while someone with hyperthyroidism may have thin hair or hair loss. Hair loss can also occur as a side effect of certain medications, hormonal changes, and stress. A patient with peripheral artery disease may have hair loss on their legs. This is why it is also important to inquire about laser hair removal treatments in our health history. Make sure to review the pictures in your book that represent the conditions such as trichotillomania and alopecia. Tinea capitis or ringworm can also occur in the scalp, where you will see areas of annular hair loss.
A nail assessment also can help us with identifying underlying pathologies. Understanding what a normal color, shape, and texture of a nail is crucial, so abnormal findings will be evident. For example, clubbing. Clubbing often indicates problems with chronic oxygenation, such as COPD. Other common nail problems are paronychias or oncholysis.
Health promotion and counseling are so important to prevent skin cancer. Topics such as avoidance of tanning beds, use of sunscreen of at least SPF 30, and the importance of reapplying are significant in assisting with skin cancer avoidance. Basal cell carcinoma is very common. These are usually small, palpable, and firm pearly areas. They're at the basal level of the epidermis. 80% of skin cancers rarely metastasize. These are examples of squamous cell carcinomas. They are located in the upper layer of the epidermis, making up about 16% of skin cancers, and they can metastasize. Melanomas arise from melanocytes in the epidermis. They make up 4% of skin cancers, and they are the most lethal. Also, the fingernails are a location where melanomas can present as a linear brown streak. As you can see in these pictures, there are different variations, irregular borders, and differentiated colors. However, melanoma does not have to include all of these characteristics. Risk factors for melanoma include light eyes and skin, heavy sun exposure, tanning bed use, severe sunburns as a child, use of immunosuppressive therapies used for HIV or chemotherapy, family history of melanoma, atypical moles or greater than 50 moles, or the male gender. Another area to make sure to not forget are the soles of the feet and, like we previously stated, the fingernails. Also, make sure to be familiar with the A, B, C, D, E, E, F, Gs of examining moles for possible melanoma. And that concludes our lecture on the integumentary system. Please let me know if you guys have any questions.